Good evening, everyone. Uh, Good evening, ma'am, Poonam ma'am. Poonam ma'am, am I audible? Good evening, everyone. Welcome to the Mahamana case discussion series. And today, although we have a very thin attendance, hopefully people will join in. So, Poonam ma'am, am I audible? And Dr. Poonam Joshi? Ma'am, your presentation is here. Are you there?
Yes, I'm there. Hello.
Hi, ma'am. Komal here.
Hi, Kumar.
Yeah, ma'am. So we'll start. Welcome, ma'am. The topic of the invited talk for today's Mahamana case discussion series is management of hypoparathyroidism post total thyroidectomy. And the speaker for today is Dr. Poonam Joshi. Madam is Professor Head Neck Surgical Oncology at ACTREC, Mumbai. Welcome, ma'am. And over to you.
Thank you, Komal, for inviting me. Coming directly to the topic. Hello. Uh, so this is the topic is role of hypoparathyroidism post total thyroidectomy. Uh, so if you see like the normal levels of hormone, what are they usually range from 50 to 60 picogram per ml. And just to see the hemostasis, how the calcium hemostasis happen, and how does that lower hypoparathyroidism due to several causes leads to difference in levels of calcium and phosphorus. We can see that the first figure shows that like post total thyroidectomy, you may have lower PTH release, and this may lead to reduced calcium and phosphorus release in the blood from the bones, and this ultimately there will be even lower absorption of calcium, and there will be thus the lower levels of calcium in the and high level of phosphorus. So this is how usually the hypoparathyroidism works. So how to make a diagnosis of hypoparathyroidism is usually it is very low levels of parathormone or minimally detectable with along with the hypocalcemia. So you have to differentiate hypoparathyroidism from other causes as well. And so if you see what is the incidence of hypoparathyroidism, we know that there are several causes for hypoparathyroidism, and among them, post-total thyroidectomy, hypoparathyroidism due to post-thyroidectomy is most common cause. And usual incidence it's a wide range, and it ranges from 1.6% to 50%. However, the incidence of permanent hypoparathyroidism ranges from 0.2 to 10%. The transient is much higher, 85 to 90%. So, what is the biochemical definition for hypoparathyroidism? So, it is usually calcium levels which are less than 1.5 millimoles per liter. There may or may not be mainly neurovascular symptoms, and usually the intraoperative PTH, if done, is usually less than 15 millimoles per liter. And if it is less than 15, which is the normal lower range of the normal parathormone level, it predicts hypoparathyroidism in the post-operative period. So usually the corrected calcium is again less than the normal range, and usually we know that the normal range varies in as per the institution, but usually you take it around somewhere above 8 to around 10 or 11 in different institutes. So usually the calcium levels are less than 8 milligram per DL, and ionized calcium is less than 3.8 milligram per DL. So if you go by the global standards all over the world, usually it's again a wide range. The transient hypoparathyroidism, usually we say it less than 1 year, and permanent would be more than 1 year, less than or more than one. So permanent, usually you will say if it is around 16%, and transient hypoparathyroidism, as per our study in our institute led by Dr. Anuja, it was around 30%, which falls into the range of transient hypoparathyroidism. However, we don't have much record about the permanent hypoparathyroidism. So there are other definitions for hypoparathyroidism. We know there is clinical, there is parathyroid insufficiency, and there is transient or temporary hypoparathyroidism. So we said that transient and temporary, earlier the definition used to be 6 months. So after surgery, if it continues for less than 6 months or more than 6 months, but now the definition has changed and it is now 1 year. So coming to causes of hypoparathyroidism, just to tell that there can be various causes of hypoparathyroidism. It is a long list, but but one of the most common causes the iatrogenic injury or vascular injury to the parathyroids while doing mainly thyroid surgeries, and it accounts for majority, around 3/4 of the cases. So what are the reasons of post-operative hypoparathyroidism post total thyroidectomy? Is mainly the devascularization of parathyroid glands during surgery, which is, we know, usually the tertiary vessels, which are very thin and supply the parathyroid gland. Usually it is, many a times it is difficult to dissect them, and they usually get injured. In those cases, there can be a devascularization of the parathyroid gland. Then the accidental removal of one or more parathyroid glands can be sometimes when there are multiple nodes, like when you are doing lymph node dissections. In those cases, while dissecting the central compartment, in those cases you can remove it by accident, or it may just look like a node, filled with node, and you can accidentally remove parathyroid glands. Many a times hypoparathyroidism can happen due to the hematoma formation, that minor vessel, there is a small bleed, you cauterize still, so at least it leads to a temporary, but depends upon the kind of hematoma formation also. So coming to the definition, whenever we are talking about hypothyroidism, hypoparathyroidism or hypocalcemia go hand in hand. So hypocalcemia, usually you say that hypocalcemia, the total serum calcium level is usually less than the normal. So again, it depends upon the center. So at our center, usually our range is between 8.6 to 10. And so you can say that below the normal range, it is usually considered as hypocalcemia. So I think we have discussed that. So whenever we are doing total thyroidectomies, usually in the post-operative period, you will, so many a times the patient may develop symptoms. So if the patient is symptomatic, we usually tend to do look for the calcium levels, because if it is very low, usually less than 7, you tend to give IV bolus. But in those cases where the hypocalcemia, you don't have any symptomatic hypocalcemia, usually you can wait for up to a second post-operative day. However, the highest sensitivity and specificity is on the third post-operative day. Most of the time, first post-operative day hypocalcemia, checking for serum calcium is not a great idea, because it can give you a false value because of the hemodilution. So what are the signs and symptoms? I think we all are aware, and we see in our routine practice post-total thyroidectomy. Usually most common symptoms are digital paresthesias, or there are perioral tingling sensation. So then there can be muscle cramping. We all know that this is one of the most like questions by the examiners also, these two signs, like the Chostek sign, which is a finding which is elicited by tapping mapping over the facial nerve as it accesses from the stylomandibular foramen, and there is increased neuromuscular irritability, which leads to the twitching of the not only the oral muscles, I mean to say the lip and the mouth. And then the other more specific sign, the Chustic sign is not very specific. However, the Trausi sign is a more specific sign of hypocalcemia, and it is usually seen in cases of usually when you the way to do it is to usually you put the BP cuff around the arm, and usually you go around 20 millimeter Hg higher than the higher systolic the systolic BP, and then you see when you go to that level, usually there is a spasm of the whole hand, and there is posture that there is we say there is adduction of the thumb, flexion of the metacarpophalangeal joints, and extension of the interphalangeal flexion of the joints. Usually it is quite painful, and it is advised, it is usually happens within the first 2-3 minutes. Hello. So then another important sign is tetany, and we all know tetany, it can be really troublesome, and it is spontaneous tonic muscular contraction, especially if it involves the laryngeal muscles leading to laryngospasm or bronchospasm. It can lead to life-threatening complications. Then there can be altered mental status. Patients can have cardiac problems, prolonged QT interval, and there sometimes can be really seizures as well. So, so then the question comes that do we need to do the perioperative calcium monitoring? Yes, we need to do, and there is enough data that usually you see the this levels of calcium at different time points, and usually if the calcium levels are falling between these periods, they can lead to higher chances of hypocalcemia in the future. Usually this intraoperative PTH we don't do at our center, but there is some data to suggest that intraoperative PTH probably can help in detecting the temporary this hypoparathyroidism. However, it may not be very significant in cases of permanent hypoparathyroidism. The cause could be because of because immediate there may be some sort of devascularization or hematoma, which may resolve over the time, and then the permanent hypoparathyroidism may not be that high. So I think usually, again, intraoperative PTH, if it goes usually below than 10 picogram per ml, usually the patient is going to have higher hypocalcemia. And so usually, but we don't do it at our center, but there's some data to suggest that it can predict the hypocalcemia. So so again, this is another question that immediate post-op PTH measurements. So intra we don't do, but subsequently over the years, in few cases, we have started doing in the post-operative PTH level. However, that does not change our management, and patients are managed mainly based on the calcium levels, and we do wait for the PTH level to come higher and the patient to become asymptomatic. So, so if you see that, what does the ATA say? Usually the PTH value, if it is more than 15 picogram per ml, again, which is the normal lower limit in adults at 20 minutes or longer post-total thyroidectomy, usually you will not need much very aggressive this treatment for the hypocalcemia. Usually less levels, which is obvious and logical also. So you will need some sort of calcium supplementation with vitamin D. So so again, I think this is, again, we all know that central compartment clearance will increase the chances of hypoparathyroidism. Again, the debate is, there will be more permanent hypoparathyroidism? Usually the temporary, we all know, the more dissection in the central compartment, the more positive neck nodes are going to be there, unilateral, bilateral. It will affect the vascularity of the glands. And again, it will depend upon if you have transplanted, the auto-transplanted the parathyroid glands. So it will depend upon all those things. However, regarding the permanent hypoparathyroidism, the results, there is no definite conclusion to say it leads to central to permanent hypoparathyroidism. So again, there is like data for this meta-analysis. This shows that usually there is higher risk of temporary hypoparathyroidism, but again, not much significant risk for permanent hypocalcemia or hypoparathyroidism. So, like what factors they do predict permanent hypoparathyroidism? I think we know that permanent hypoparathyroidism, it will depend upon the extent of surgery, the involvement, the stage of the tumor. It will involve the extent of the nodal involvement. It will even depend upon the expertise of the surgeon and the number of cases a surgeon does in a year. Then it depends upon naturally the biochemical levels, what you get in the immediate post-operative period. If PTH level is low, it is obvious that the patient may have high chances of hypoparathyroidism. And then naturally, the more the decline, the higher the chances of hypoparathyroidism. Again, if there is much decrease in the magnesium levels. So does the parathyroid autotransplantation help in reducing the hypoparathyroidism? Yes, we do know that usually whenever there is by mistake or by inadvertently you remove a parathyroid gland, or there is devascularization while doing a neck dissection or doing a total thyroidectomy, we have to autotransplant the parathyroid gland. Usually where do you autotransplant these parathyroid gland? Usually parathyroid gland is minced into multiple pieces and that very small pieces, and then it is usually put into the sternocleidomastoid forearm, we used to say, but most of the time it is not done in the forearm. It is usually, and then you can put it in the muscle or subcutaneous adipose tissue also. So I think we all know that how does it happen? Usually there is congestion of venous. So there is one technique that how can you improve the vascularity? Usually the first there is you can just put a small nick, and usually it reduces the venous congestion. So that probably sometimes can help in the recovering of the bleeding of the vascularity of the gland. So again, do we need to do parathyroid autotransplantation whenever there is total thyroidectomy and we have inadvertently removed it? So ideally, you should do it whenever it is possible. And I think there is enough data to suggest that it actually decreases the incidence of the permanent hypoparathyroidism. But usually it takes 6 weeks to 8 weeks for it to become normal, because those minor tissue, they usually develop their blood supply from the surrounding muscles, and it takes time for it to happen. So usually auto transplantation of the parathyroid glands during central neck dissection, again, this is another study, and it shows that the risk of this is like around 0.9%. As the number of nodes increased, it becomes more, and usually it helps in if you are doing auto transplantation, it may reduce the chance of permanent hypoparathyroidism. So should all, so again, the question comes that usually when we do a parathyroid, not parathyroid, a post-total thyroidectomy, it's very common. Again, we know the minor vessels, when we do a total thyroidectomy, vessels are very fine. Even if you are very meticulous, many a times you are going to injure those minor vessels, and this can lead to the injury to it can lead to discoloration of the parathyroid glands. And so what should we do? If there is a discolored parathyroid gland, should we remove it, or should we, so whenever there is a discolored parathyroid gland, should we remove it? No, we should not, because most of the time it could be because of the venous congestion, or it could be because of this temporary vasospasm of the vessels. So usually in those cases, it is recommended that we have to keep this thing intact, and we need not to remove it and do auto transplantation. So I think we all know the basic procedure. So you have to mince it as much as possible, usually very thin pieces. The more because the thinner it is, the easier for it to develop its blood supply, and there is a higher chances of uptake from the surrounding tissue. So I think we have many slides on this. So I think we have to understand that we have to do auto transplantation whenever we have a parathyroid blood supply inadvertently, the parathyroid is removed or parathyroid blood supply is not there. Mince it and then auto transplant it. So again, there is meta-analysis, and we know that you have done more number of auto transplantation of parathyroid, multiple removed, you did auto transplantation as compared to not, it will affect the post-operative outcomes. So now there is like, do we need to do a pre-operative vitamin D, and does the vitamin D deficiency will make a difference? So that we have to see that usually at our center, we usually don't do a pre-operative this thing, but in case you are doing, you can start the patient even for the vitamin D supplement in the very beginning. So I think there is some data to suggest if there is a severe deficiency, naturally it will lead to hypoparathyroidism, because it will affect the hemostasis of the calcium hemostasis. So naturally, so the more number of parathyroids you can identify, the better it is, because if you can identify more parathyroids, you have not removed it in the specimen most of the time. So it is usually suggested that you go ahead first, do it with the superior parathyroids, because superior parathyroids have a more consistent location as compared to the inferior parathyroids. So usually in my practice, what I do is I go with the superior parathyroids, at least to the side which I am operating, and then I try to look for the inferior parathyroids. So that probably helps us in preserving the parathyroid, at least the superior, whenever usually there's a large nodal mass in the bilateral central compartment. So that's a practical tip you can do. So does the surgical technique affect post-operative hypoparathyroidism? It does affect. We know if you are having a larger tumor, multiple nodes, total thyroidectomy, like I said, even the experience of the surgeon, so that all makes a lot of difference to the outcomes. And naturally, the more you are careful with if you are ligating the tertiary branches of, you're doing of inferior thyroid artery, you are doing it like a subcapsular resection. In those cases, there's a higher chance that you'll be saving the blood supply to the parathyroid glands, and subsequently less chances of post-operative hypoparathyroidism. So there can be several problems in parathyroid preservation during surgery. We know, like I said, that it may be a huge disease. Sometimes it may be even infiltrating the parathyroid glands. It is so distorted, you can't see the real anatomy of the of the thyroid gland along with the parathyroids. So variations, which is mainly with the inferior parathyroids. Then there can be blood supply, there can be multiple branches, or there can be a very fine branch, so we have to save it, but sometimes it can be technically challenging, and you may not be able to identify the parathyroid gland properly. Sometimes you may, especially when you are in like earlier part of your career, sometimes you can easily confuse your parathyroid with a node, with a fat piece of fat, or you can sometimes even get confused with the thyroid gland. So a proper identification of parathyroid gland while doing a thyroid surgery is very important to save it. And we know there are now a lot of adjuncts to help with that, like ICG, like even there are other modes to do it. So does utilization of loops help? I think we all know, even for our thyroid recurrent laryngeal identification, it does help. And if it is you have a loop and you have practice with it, it is usually a better idea to do it with a loop. And there is data to suggest that with the loop, because the identification of parathyroid glands, the blood vessels, the recurrent laryngeal nerve naturally is much more enhanced, much more enlarged. It becomes easier to see the fine vessels also. So it does make a difference. So does using energy devices they increase the incidence of injury to the parathyroid glands? We know that naturally, if you are using very high energy devices, even I have seen in my own practice also, that if you use a monopolar cautery, even though I don't have a data enough this they would suggest in my own practice, but then you do injure the blood vessels around the parathyroid. So it's important that you be very meticulous when you are doing a dissection, mainly the subcapsular dissection, trying to clip the tertiary branches, and then or bipolarizing them very carefully. So So we all know that in the post-operative period, usually hypocalcemia is the hypoparathyroidism, which ultimately manifests as the hypocalcemia, is treated with the oral calcium and your vitamin D. And there are usually, you can put it as like, if it is a do we give our patients oral calcium without seeing the level of calcium? Earlier in our practice, we used to give, there was some data also that usually giving 500 milligram TDS may reduce the risk of post-operative hypocalcemia, but we should not take it as a blanket statement. I think we have to go by the calcium levels, and if the calcium levels are well within the normal range, and the patient is not symptomatic, you can in fact wait also. So I think again there is like post-operative vitamin and calcium routine supplementation should we do. So again, there is data to suggest that if you are giving, there can be significant decrease, and even giving both calcium and vitamin D may be further helpful. But again, I would say you have to see again your case, and depending upon the case, you have to do it. If you have been very meticulous, and usually you have to give it for some time, even if you are giving it is usually for 2 weeks or 1 week, maximum 2 weeks we have seen in our practice, and by that time usually the levels of calcium they stabilizes. So again, adding that helps in the absorption. We know the calcitriol, it helps in the absorption of the calcium, and this it can be given prophylactically also. But again, I would say we should go as per the post-operative levels. So again, what can be done intraoperatively? I think we already had discussed that how do we do it. We had to save all the blood supply. Again, superior parathyroids are easier to identify, and inferior also you can look at too, but usually they are difficult most of the cases when there are multiple central compartment lymph nodes. And is usually when the gland is dark, you can leave it if the blood supply is intact, I would say that, but this again can be debated. And most of the time you have to do auto transplantation when it is detached from the blood supply completely. In those cases, you can you definitely have to do a auto transplantation. So again, I think we all know how is the post-operative hypocalcemia is managed. Usually acute phases, you give calcium, IV or oral, along with the vitamin D supplement. And in most of the cases, the patients, they recover in a month. And in those cases, when it becomes chronic, and in those cases also, most of the time we continue with higher doses of calcium and we titrate the levels. We keep on seeing the levels. But one thing we have to be careful is what formulation we are giving to the patient, because different formulations will have different doses of elemental calcium. So please look into that what kind of formulation you are giving. Again, I think we all there is now recommendation from this second international parathyroid workshop that you can give parathyroid hormone replacement, but we should not be opting it for regularly, and only those cases where it is resistant to all kind of oral or IV treatment. In those cases, your parathyroid hormone replacement can be done, and you can manage the hypoparathyroidism. With this, I conclude my lecture. Thank you.
Thank you, ma'am. It was indeed a very extensive coverage of the topic of post-operative hypocalcemia. And I think you covered all bases. Thank you, ma'am. And now we move on to our next session, which is the case presentation. So today's case presentation is by Dr. Ginny Rajan, who is a resident at RCC Trivandrum. And her topic of presentation is differentiated thyroid carcinoma. The examiners for this case presentation are Dr. Jyoti Davolkar, ma'am. Madam is currently senior consultant at HN Reliance, Sir HN Reliance Hospital in Mumbai. She is ex-professor in head ENT and head neck surgery at KEM Hospital, Mumbai, and president of the Indian Society of Thyroid Surgery. Madam, are you there? I don't see her in the list also. Probably I'll try to contact her. Next, we have Dr. Elizabeth Ait, ma'am. Madam is professor in head neck surgical oncology at RCC Trivandrum. And welcome, ma'am.
Thank you.
And next we have Dr. Ratan Shetty. Dr. Ratan Shetty is Associate Professor in Head Neck Surgical Oncology at ACTREC, Navi Mumbai. Welcome, Dr. Ratan.
Yeah, thank you. And good evening, everyone.
And Dr. Ginny Rajan, over to you. Please share your screen.
ചായ ഉണ്ടോ കഴിഞ്ഞോ
May I start, ma'am?
Yeah, please
ചായ
go ahead.
ഉണ്ടായിരുന്നു ഉണ്ട്
I request all the attendees to mute their mics. Somebody is asking for tea.
Good evening, all. Respected teachers. My patient is a 43-year-old female. She is a homemaker, resident of Trivandrum, presented with the chief complaints of anterior neck swelling for 3 years. History of presenting illness. Patient was apparently normal before 3 years and noticed to have swelling in front of neck, which was small of the size of a peanut to start with and gradually progressed to present size. Swelling is not associated with the pain, no history of breathlessness, dysphagia, hoarseness of voice, noisy breathing, and there are no symptoms suggestive of hypo or hyperthyroidism. No history of bony pain, bony swellings, jaundice, loss of appetite, or significant loss of weight.
Yeah, Jenny, I have a question. Did the patient say that she has an anterior neck swelling? What was the patient's complaint?
Neck swelling, sir.
Do avoid saying anterior neck swelling. This is a medical terminology. So when you narrate history, don't use medical terminologies. Or some old examiners might take offense to this.
Okay, sir.
Okay.
Coming to
Okay, go ahead.
Yes,
Yeah,
sir.
yeah.
Coming to past history, she's not a known case of diabetes mellitus, hypertension, bronchial asthma, CAD, or pulmonary tuberculosis. No history of previous neck irradiation in childhood, and no history of previous surgeries. Personal history, she consumed mixed diet. She's having normal sleep and appetite and normal bowel and bladder habits and no addictions. Menstrual history, she's having regular cycles. She's married and having 2 children, and last child is of 5 years old. Family history, there is no family history of malignancy.
Could you please summarize the history again for me?
Yes, sir. My patient is a 43-year-old female, presented with the chief complaints of neck swelling for 3 years, which was which started with the size of a peanut and gradually increased to the present size. There is no history of pain associated with the swelling, no pressure symptoms, no symptoms suggestive of hyper or hypothyroidism, and no significant family history, no history of neck irradiation, no comorbidities, and no symptoms suggestive of metastasis.
No, and when you summarize, you only say the positive points. However, you did not mention what is the present size. You said present size. What is the present size now?
Present size is size of means it has reached up to size of an almond.
Size of an almond.
Yes.
And before it was size of a peanut.
Oh, yes, sir. Approximately 2 centimeter size, sir.
All right. See, you can say that. You can say that. So when you say almond and peanut, some peanuts are bigger than almonds. All right. They are small. So avoid using terminology which can confuse the examiner. Madam, you have any questions, madam?
Ginny, maybe when you say the size according to the patient's history, this is saying about history, right? So in the history, maybe you can see that it was smaller in size and gradually increasing in size according to the patient. Maybe you can avoid all these terms.
Yes, ma'am.
That is one thing. Yeah.
May I proceed, sir?
Yeah, please
Yes, you
proceed.
can.
Coming to general examination, ECOG score is 0. Patient is conscious, oriented, cooperative, moderately built and nourished, febrile, no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy, and there are no specific eye signs. Vitals, BP is 120/70 millimeters of mercury measured in left upper limb in sitting position. Pulse rate is 84 per minute, regular in rhythm, normal in volume and character, no vessel wall thickening, all peripheral pulses felt equally bilaterally. Coming to local examination of neck, on inspection,
Ginny, one more suggestion. Don't say no eye signs and all that. Then the examiner will ask you to describe all the eye signs in here in hyperthyroidism. So don't make such comments. You will be inviting trouble unless you are very thorough with all the eye signs.
yes, sir.
Are you thorough with all the eye signs?
There are certain eye signs in
No, just skip it. I mean, this is proceed with the presentation. We'll ask in the inspection and palpation.
local
Right.
examination.
So, yeah, go ahead.
On inspection, there was approximately 2 into 1 centimeter swelling in front of neck at the region of thyroid gland. Skin over the swelling was smooth, no redness, scar, sinus, or fistula. Swelling moves with the swallowing and not with protrusion of tongue. Lower border of the swelling is visible. Trachea appears to be in midline. No visible pulsation or dilated veins or neck. No other visible swellings in the neck.
Okay, good.
On palpation, no local rise of temperature or tenderness. Swelling was 2.5 into 2 centimeter in size in the right lobe of thyroid gland near the midline, which is hard in consistency, mobile, and lower border of the swelling was palpable. Skin over the swelling is pinchable, no palpable thrill. Carotid pulse felt bilaterally. Trachea is in midline, no palpable cervical lymph nodes. On percussion, it is resonant over membrane sternate. On auscultation, no systolic bruit heard. And on video laryngoscopy, bilateral vocal cords are mobile and glottic space is adequate. To summarize, she's a 43-year-old female presented with swelling in front of neck for 3 years, which is with a gradual increase in size without any pain or pressure symptoms or symptoms of hyper or hyperthyroidism. On examination, 2.5 into 2 centimeter hard mobile swelling in the right lobe of thyroid near midline without retrosternal extension, and patient is clinically in euthyroid state.
Ginny, have you mentioned the system examination? I couldn't hear.
She has mentioned one.
Okay, yeah. So along with the local examination, you have to complete it with system examination, cranial nerve, skull and spine. That's general for all the head and neck examination.
Cranial
Okay.
nerves, I don't think she has mentioned.
Only the VLS finding. Okay.
Yeah.
Diagnosis, it is a solitary thyroid nodule and patient in euthyroid state.
When you summarize also, it has to be in 2-3 sentences only, just the history, the finding, everything together. You don't have to mention on examination and all in between the sentences. Okay. It's just a summary of what you have heard and what you have palpated and examined. So it's in 2-3 sentences continuous. Yeah. Okay.
So, Ginny, how would you like to manage this case? What is your diagnosis? Your diagnosis is?
Solitary thyroid nodule in euthyroid state. Sir, first of all, I would like to explain the nature of disease to the patient, and I'll counsel the patient regarding need of further investigations to confirm whether it is benign or malignant. First of all, I'll order for a thyroid function test. After confirming the thyroid status of the patient, I'll go for a ultrasound neck with a guided FNA from the suspicious nodule.
All right.
So this
So
was
what do you want to do a TSH in the beginning?
to know the thyroid function status of the patient, sir. Usually in hyperthyroid state, after making the patient euthyroid, we proceed with the ultrasound or FNA.
What if a patient is hyperthyroid? What will your next investigation be?
Sir, yeah, if it is a hot nodule, there is a 5% chance of malignancy. So after making the patient euthyroid, we can go ahead with either surgery or radiation ablation. If the patient is having cold nodule, then we have to go for USG to characterize the nodule and FNA if there is any high suspicious features of malignancy. In cold nodule also, there is 10 to 20% chance of malignancy.
All right. Why women have more thyroid nodules compared to men? What is the physiological reason behind this?
Women is having more thyroxine requirement.
No,
More,
that's not the reason.
more
Where
TS,
is that? Where is TSH secreted?
pituitary,
Which part of pituitary?
anterior lobes,
Anterior pituitary. What other hormones are secreted by anterior pituitary?
ACTH, TSH, growth hormone.
What other? Is FSH secreted by anterior pituitary?
Yes, sir.
What does FSH do?
Follicular stimulating hormones.
All right. Does it have any relevance to why women have increased incidence of thyroid nodules?
Not sure, sir.
So please read about this.
Sure.
And there are structural analogy to this. Alpha subunit of the glycoprotein is similar of all the anterior pituitary hormones. Only the beta subunit has biological specificity.
Okay.
All right. So that's the reason, because cyclical menstrual cycles can stimulate thyroid also. So that is one of the reasons why women have increased incidence of thyroid nodules. And okay, please read.
Ginny, what is the incidence of a solitary thyroid nodule in general population?
Ma'am, generally it is 5 to 15%. In females, it is 4 to 15, and in males, it is 7 to 20%.
What about the incidence in an autopsy? It's approximately around 30%. So why I did ask this question is, when will you evaluate a solitary nodule thyroid? Because you said it's common in the incidence is in general population is around 12% or 15%.
Yes,
And even in autopsy, it is around 30%. So the patient comes to you with a solitary nodule thyroid. So when will you think of evaluating a patient with solitary thyroid nodule?
if the USC showing any high,
No, you haven't done anything. You haven't done anything, investigation or anything. Just after your clinical examination, you identified a solitary nodule. So when will you think of doing a?
it can be divided into patient factors and tumor factors, ma'am. Patient
Mhm.
factors like age less than 15 years or more than 55 years, if it is a male gender, and if there is any family history of thyroid cancer, and if childhood history of neck radiation, and tumor factors like on an examination, if it is a hard nodule um, with the pressure symptoms and with the fixity to surrounding structures and associated lymph node enlargement. In such cases, we have to evaluate.
Yeah, very good. So you after examining the patient, you have to think about all the probabilities of getting a malignancy. So then only you will start evaluating. So extremes of age, male, gender, family history of CA, history of radiation, neck nodes, pressure symptoms, distant med suggestions, heart nodule on palpation. All these cases you will have to evaluate.
Yes.
Okay. Yeah.
So this patient had in USG 2.4 into 1 into 1.8 centimeter Tirade spine nodule on the right lobe and 7 into 4 mm Tirade spine nodule on the left lobe. And there was no cervical lymph nodes. On FNA from the right thyroid nodule, it was Bethesda 6 suggestive of papillary thyroid ceiling.
No, you have to mention the importance of Tirades here. You said thyroid function test first, then you will go to ultrasonography.
Yes, ma'am.
So what are the things, what are the 5 main things you want to assess to categorize your Tirades?
There are 5 features of thyroid nodules in ultrasound, ma'am. One is composition, echogenicity, shape, margin, and echogenic foci. Composition can be purely cystic or spongiform, partially cystic and solid, or purely solid. And echogenicity can be anechoic, iso or hyperechoic, hypoechoic or very hypoechoic, and shape can be wider than tall and taller than wider, and margin can be smooth, ill-defined, irregular, low-bladed, or with the extrathyroidal extension, and echogenic foci can be large cometal artifact, microcalcification, and punctate echogenic foci.
Dr. Shetty, you can ask because Ginny is our student. So I
Okay.
know her well, how far she can answer.
Okay.
So you can be the
Okay,
chief
Ginny,
examiner.
you have a patient who has got a CT scan. There is an incidentally CT or a PET scan. You have an incidentally detected thyroid nodule. Would you still ask for an ultrasonography? If yes, then why?
To characterize the nodule, ultrasound will be better, sir.
What is better in the ultrasound?
The nodules characteristics, sir. As I said, the composition, shape, margin, echogenicity, and all.
Yeah, echogenicity. That's the reason. All right, always get an ultrasonography in a thyroid nodule.
And for grading into Tirades 1 to 5.
Okay, now you have done an FNAC. FNAC is showing papillary shape. What about the other nodule? Did you do an FNAC, poke a needle into the other nodule also?
No, sir. We have done FNA from the right side nodule.
What is the difference between multicentricity and multifocality?
Multifocal is in different locations, sir.
No. Multicentric is bilateral,
Okay.
whereas multifocal is different nodules in a single lobe. Okay, it's analogous to breast also.
Okay.
Same things are there in breast malignancies. Multifocal and multicentric. So in this case, what is it? Multicentric or multifocal?
Multicentric.
Yeah, the other lobe also has a nodule.
Yes.
We are not assessed it.
Yes.
So how would you like to manage this case?
Yeah, before that, Dr. Shetty, about that hypoechoic nodule, Ginny, you were telling about that. So echogenicity, how will you compare the echogenicity of the nodule?
To what?
Hyper and hypo. Ginny?
Yes, ma'am. Ma'am,
You said hypoechoic. So you have to compare with the surrounding normal tissue, especially the strap muscles. So hypo or hyper, that is more brighter or dim. That is what you meant by hypo or hyper. So you have to compare it with the surrounding normal tissue. And then that's how. And one more thing about this ultrasonography. What do you mean by elastography and what is its importance?
Ma'am, elastography is a non-invasive imaging technique. It has an added advantage, we can avoid unnecessary FNAs. It assesses the elasticity and stiffness of the nodule.
Yeah, there is a score according to the stiffness of the tissue. And
Malignant,
3-4, yeah.
More stiffer, while the benign nodules will be softer.
Yeah, it is not into the guideline, but it is a non-invasive imaging technique to identify your malignancy according to some score with all the stiffness and the velocity of the tissue. So what do you mean by taller than wider?
In transverse plane, it is measured in transverse plane, ma'am. If the nodule is taller in transverse plane than wider, it is having 3 points, while the wider than tall is having 0 points. That is benign.
Okay, the tumor always grows vertically with invasive features. That's why that is a characteristic of
Malignant
malignancy.
nodule.
Yeah.
Among all the features, which is the most sensitive for malignancy?
Most taller than
No. It's given in ATA guidelines.
ecogenic.
So what are the features suggestive of malignancy, Ginny?
As a solid hypoechoic and with a irregular or lobulated or infiltrative border with a microcalcification or peripheral rim calcification, taller than wider, and presence of extrathyroidal extension.
Okay.
Extra
Microcalcification. Okay. So what? How do you? Is there any grade of extrathyroidal extension?
minor. Previously it was there, sir. Now it is removed from T3A and T3B. Minor and major extrathyroidal extension. Now it is changed.
On imaging.
Imaging not shown.
Okay. And so we'll proceed with the management, madam.
Yeah, yeah. Anyway, let her tell about Bethesda and all because she has
Okay.
already mentioned FNAC.
So what does Bethesda 1 mean? What does Bethesda 6 mean? What is the risk of malignancy?
So
2023 Bethesda.
Sir, according to third edition Bethesda 2023, Bethesda 1 is non-diagnostic, Bethesda 2 is benign, Bethesda 3 is ATP of undetermined significance. Previously, AUS and FLUS was there. Now it is only ATP of undetermined significance. And it is further divided into with nuclear atypia or other atypia. And nuclear atypia is having more cancer risk. And Bethesda 4 is follicular neoplasm. Previously, suspicious follicular neoplasm was also there in Bethesda 4. Then Bethesda 5 is suspicious of malignancy. And Bethesda 6 is malignant.
Okay. They've
And
simplified it. All right.
risk of malignancy previously range of numbers were there in percentage. Now single means now single numbers is used in percentage.
All right.
What do you
So-
mean by NIFTP?
Ma'am, it is included in Bethesda 4. It is non-invasive follicular thyroid neoplasm with the papillary-like nuclear features. It is previously low risk PTCs. Now it is included into NIFTP.
Is it benign or malignant?
It is Bethesda 4.
Yeah, how will you manage NIFTP?
NIFTP, we can do lobectomy, ma'am.
Sure.
And surveillance also we can do.
Yeah, the first thing should be active surveillance for an NIFTP, just like your Bethesda 3 and 4. Okay.
So how will you manage your case?
Sir, I'll counsel the patient for surgery since there are Tirax 5 nodules on both lobes, and it is better to go for a total thyroidectomy, sir, for this patient.
Your points favoring total thyroidectomy.
Sir, in right lobe, it is more than 2 centimeter nodule with a Tirax 5, and in left lobe, it is less than, still it is less than 1 centimeter. It is also Tirax 5. Since there is bilateral lobe involvement, it is better to go for total thyroidectomy.
Do you do a CT or MRI here? Any cross-sectional imaging here?
Patient, it is not indicated, ma'am. This patient is not a high risk. She's not coming under high risk category. Like she's a female, not meeting that extreme age criteria also, and she's not having any family history of thyroid cancer or any history of neck irradiation. And tumor wise also, nodule is though it is hard, it is mobile, and the lower limit is palpable. And there was clinically no lymph node mets, and USG-wise also there was no lymph node mets. So in this patient, it is not really.
So mainly in the extremes of age and other high-risk factors also, lymphadenopathy, pressure symptoms, lower extent not palpable. In such cases, you have to go for a CECT ideally. When will you do MRI? Any specific or additional benefit of doing an MRI?
MRI in advanced cases we can do, like if we are suspecting any recurrent laryngeal nerve involvement or laryngeal or tracheal involvement, esophageal involvement, prevertebral space or muscle invasion. In such cases, we can go for MRI.
Yeah, mainly for the esophageal and the prevertebral space invasion.
Okay.
Yes.
The rest of the things you will be able to make out with CCT.
Yes, sir.
What other investigation will you order if you are suspecting airway invasion?
A bronchoscopy we need to do, sir.
And bronchoscopy and
Assessment of the lesion, sir. How much it is involved, trachea. If tracheal invasion is there, how much?
so
it is,
what will you look for in bronchoscopy?
that shin grading, sir. If it is means in shin
You
for
will see. So what will you look for in bronchoscopy? What will you ask the patient to do?
any, if there is only compression of the trachea, or if there is a breach of the mucosa and intraluminal ulcer or mass in the within the trachea, sir.
Okay. So Shin is a pathological classification. Remember that, but it is being used for diagnostic also.
Okay, sir.
So what is Shin classification? What is Shin 1, 2, 3, 4?
So Shin 1 is abutting the external perichondrium. Shin 2 is invading the cartilage. Shin 3 is invading the submucosa. And Shin 4 is invading mucosa, causing intraluminal mass or ulcer.
Okay, you have a what are the okay, so you are going to plan surgery for this case.
Yes,
So what is your extent of surgery? Total thyroidectomy.
total thyroidectomy.
Would you also like to do before that? How do you stage this tumor?
It is clinically T2, N0, M0.
All right.
Stage
So
1.
stage 1. Because less than 55. What is
Without-
stage? Is there any stage 3 and 4 in age less than 55?
Sir, it is only stage 1 and 2 without medicine.
What is the difference between ATA risk stratification and TNM staging?
TNM staging, T1 is divided into T1A and
No. What is TNM staging and what is ATA? What is the risk in ATA? Risk
TNM,
stratification.
sir, TNM is pre-operative staging, sir.
No.
Risk stratification we do after the completion of the initial treatment, sir.
TNM is survival based, whereas ATA risk stratification is risk of recurrence.
Yes, sir.
Okay.
Yes, sir.
ठीक कुछ खाएंगे ना ना बस खाली और क्या खाएंगे ना 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 नहीं
Somebody was speaking.
Ginny, you want to tell something about Bethesda 3 and 4? When will you do molecular testing? What are the rule in, rule out test?
Yes, ma'am. Instead of going directly for active surveillance or lobectomy, this molecular test act as a supplementary test to assess pregnancy risk. So there are rule in and rule out tests. Rule in test is the test with a high specificity and high positive predictive value. While rule out test is test with a high sensitivity and a high negative predictive value. When the sorry. When the test is positive, it rules in disease, and when the test is negative, it rules out disease. Commonly in Bethesda 5, we do a ruling test, and in Bethesda 3 and 4, we do a rule out test. And the Tyrosec and Tyrosec and Tygenex are ruling tests, while Afirma is rule out test. Thiramer is both rule in and rule out test.
Very good. You have done your reading. And one more thing, which nodules will you observe? Active surveillance.
Active surveillance, it is again classified into 3 types, sir. Ideal candidate, appropriate candidate, and inappropriate candidate. The ideal candidate, it can be based on patient factors, tumor factors, and institute factors. Patient factors like unifocal disease with a well-defined margin, with a normal surrounding thyroid parenchyma more than 2 mm, without extranodal extension, and with no lymph node mets or distant mets. And the patient factor is patient with the old age, like more than 60 years old, and who is willing for active surveillance, and patient with the life-threatening comorbidities, and patient who is aware that there will be a chance of surgery in future if there is any progression of disease, and patient who is compliant to the follow-up plans, and an institute factor is institute with a good experienced MDT team, and high quality ultrasound, and for proper institute with a good data collection team, and for tracking.
Yeah, you've done your reading, but you didn't even mention the most important thing, which is the size. What size? Will you observe a lesion which is 5 centimeter across?
Less than 1 centimeter micro PTC we can observe, sir.
All right. Do you know any evidence for supporting this?
Sir, in a study by Ito and Sugitani in Japanese studies, the prospective study, they evaluated in 1365 patients, sir, and in that around 191 patients only required surgery. They followed up the patient for 6 years.
Okay. How many
So
died?
in active surveillance, how are they following it up? How frequently? The Japanese study?
They have to do ultrasound 6 monthly, and if there is any increase in size more than 2 mm or more than 20%, or increase in volume more than 50%, then they'll have to go for surgery.
And how many died in this series?
That is not sure.
Nobody died.
Okay.
So you should read your study, read your evidence well.
Yes,
And you should know the sample size also. Nobody died. That's why active surveillance is something which is accepted now.
sir.
10 years ago, it was not something which was. And when was this article published?
Not sure. I'll see.
Okay, all this is relevant. Okay. Madam, you have any questions?
Yeah, she was telling about this molecular testing very nicely about rule-in test and rule-out test. Why it is not really practical in our country?
It is very costly, ma'am. It costs around more than 1 lakh, and most of the patients won't be affordable, and it has got it doesn't have that much specificity also.
Yeah, they say about only the probability of getting malignancy and also the cost and it's not freely available. The unavailability and the cost, and only they can say the probability of the malignancy. That's why it's not really, and we don't have that much of insurance coverage for all these things. You said about rule out test is to confirm it as benign, and rule in is to confirm it as malignant. So one is more sensitive, that is rule out. What do
Yes.
you mean by sensitivity? How do you calculate sensitivity? There is an equation or a formula for that. Just because you're answering everything, I just want to deviate. That's all.
Divided by true positive plus false negative.
True positive by true positive plus false negative. And specificity?
True negative divided by true negative plus false positivity.
Okay, good. So sensitivity is related to the positive predictive value. That is true positives.
Yes.
Specificity is related to negative predictive value. That is true negatives. Okay. So that's how we do this. And anyway, and what are the mutations or the molecular markers you are testing in this this next generation sequencing? Can you mention some of the markers?
BRAF V600E, RAS, mainly KRAS, HRAS, and NRAS, and RET PTC, and PAX8 PPAR gamma. These are the main genes tested.
Okay, which are the markers which show aggressiveness of the tumor?
BRAF V6,
No, no. BRAF is actually a good prognostic thing.
third mutation. Third
TERT and P53.
P53.
Which shows like poorly differentiated or undifferentiated tumors, it will be more expressed. TERT and P53. Okay, so the molecular testing is actually in Bethesda 3 and 4, and also for what do you call the prognosticate the patient, and also for targeted therapy in recurrent lesions to assess the mutations and the marker sensitive, the expression. To prognosticate your patient, also in recurrences, to know about to plan about your targeted therapy and all.
Yes.
So in that case, what do you mean by that is targeted therapy? Just because I mentioned that.
Targeted therapy, we can do IHC and CMAM. This BRAF mutation is seen in radioiodine refractory PTC. So in that case, we can give dabrafenib, vemurafenib, or MEK inhibitor like trametinib, and PD-L1 we can test, and if it is positive, we can give immune checkpoint inhibitor like pembrolizumab and nivolumab, and in P53 positive or K increased K67 value, it is mainly indicative of ATC or poorly differentiated thyroid cancer. In that case, we can give lenvatinib, sorafenib, and in MTC, we can do ALK testing. In that, we can give crizotinib.
So,
You have read
Ginny,
well.
yeah, you have read very well, but let's be practical here. What is the indication of TKIs in thyroid cancer? When will you give?
Sir, we can give in radiorefractory cases and poorly differentiated cancers, and if some case of anaplastic thyroid cancer.
Okay. No, we are talking about differentiated thyroid cancer. Don't talk about anaplastic or medullary or all that. Radiorefractory, yes. What is radiorefractory disease?
Radiorefractory, it can be like, it is again classified into four, sir. It can be that tumor tissue never concentrate radioiodine, or tumor tissue which loses the ability to take up radioiodine, but there was previous evidence of radioactivity, and it can be tumor progresses in spite of significant radioiodine ability. These all radiorefractory cancers.
Okay, there is radiorefractory disease. Patient is asymptomatic. Still, will you give TKIs? Structural disease is there. You are not able to surgically resect it. Probably there may be distant metastatic disease also. Still, would you like to give TKIs? When will you
Sir,
give
if
TKI?
tumor is rapidly progressive,
Only when the patient is symptomatic.
symptomatic,
Why?
rapid
What are the complications of TKIs?
TKA, TKA cannot be given in cardiac patients, sir, and patients with coagulopathy, or patients with
See,
Uh,
these are not Ganga Jal. So whenever you give TKIs, they can have complications.
Yes,
Read
sir.
about the complications of TKI. The indication of TKI, like you mentioned, is in symptomatic patients who may be progressing fast.
Yes,
Patient is asymptomatic, you can manage conservatively. Now coming to the case, so you are doing total thyroidectomy,
yes,
isn't it?
yes.
So what approach will you do?
Conventional total thyroidectomy.
Conventional. Okay. What are the steps of total thyroidectomy?
So first of all, lower skin crease incisions, then subplatysmal flap elevation, um, uh, 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 this dissecting subplatysmal flap elevation, and strap muscles will be embedded in the midline, and it will be retracted, identifying that exposing the thyroid gland. And first of all, we have to identify the middle thyroid vein. It has to be ligated first. Then superior pole and inferior pole has to be ligated close to the serving the recurrent laryngeal nerve and external branches of the laryngeal nerve and all parathyroid glands and
Okay.
glands.
The patient has a functioning now. You found a central compartment node sitting on the now, probably engulfing the recurrent laryngeal now. What will you do? How will you manage? Patient has a functioning cord. And you have access to INM. Do you use INM in your surgeries?
No, sir.
Okay. So you have access to INM. It's a functioning now. How will you manage?
If we have access to IONM, we can try to remove the node, sir, without disturbing the nerve.
फॉर्मलिन का चैम्बर ढक्कन खुला है हम लग रहा.
Yeah, go ahead, Ginny.
So we can try to remove the node, sir, without disturbing the nerve integrity. If we have access to IONM.
If you don't have access, still you will live and disease.
Or we can shave it off from the nerve, sir.
Yeah, you can safely shave it off. Then if you can do it, definitely shave it off. Does R1 resection have any relevance in outcomes in thyroid cancer?
After R1 resection, we'll have to go for permanent ablation, sir.
Yeah, radiation therapy. All right. Don't leave behind any gross disease, but try to remove as much of tumor as possible. Suppose, what are the indications for nerve sacrifice? Functioning now.
Functioning now, if the
It's a difficult question.
nerve is adherent to the tumor, sir. If the nerve is passing through the tumor.
But you have disease all over the neck. Would you still go ahead with nerve sacrifice? Patient has distant metastatic disease. Would you still sacrifice?
No, sir. We'll preserve the function, sir. If
So,
patient
so
from
can you see me? Can you hear me?
Good evening,
Yes,
Jyoti
madam.
ma'am.
Yes.
Yeah, but I can't see anyone.
Good evening, madam. We are there,
but
madam.
I can't see anyone.
Okay, we have switched off our cameras, madam.
Ma'am,
Yeah,
would
good
you
evening, madam.
I don't need it. I don't need it. So I can read a question. FNSC right thyroid nodule, TB-SRTC 6. So suggestive of papillary thyroid carcinoma, right?
yes, ma'am.
Yes, madam.
Okay. So is the student can see hear me? What is the name of her?
Ginny Rajan.
Okay. So I want to ask a question that what is the percentage of Bethesda 6 being cancerous?
Now 97%, ma'am.
Huh?
97%.
Absolutely. So basically it's an institute variation. It also depends on the expertise of your pathologist. But
Yes.
this is sure shot cancer, and you have to plan your surgery, workup, everything properly, like you are dealing with cancer 100%.
Yes, ma'am.
So what will be your workup?
Ma'am, after Ma'am, I'll do the routine blood evaluation, ma'am. We have
Yeah,
done.
that is, yeah, for GA fitness, you will do everything.
Yes,
But related to thyroid, would you like to, now you know it's a thyroid cancer, well differentiated probably from the FNSE, but it is a papillary. But what is a characteristic of a papillary? What is the characteristic of papillary?
calcifications,
No, behavior wise.
indolent.
Yeah, indolent. So that doesn't mean you will not operate. But what I mean to say is that they have a high propensity for the lymph nodes.
Lymph node mets.
Yeah, they have a high propensity.
Yes.
So, as a clinician, if you want to do a complete surgery in the first go,
Yes.
your workup to find out whether the lymph nodes are involved or not should be very thorough.
Yes, ma'am.
So, what will you do for that?
For picking up lateral lymph nodes, the sensitivity of ultrasound and CT is similar, ma'am. It is around 79% for both. And for picking up the central compartment nodes, we'll have to go for cross-sectional imaging like CT, ma'am.
So,
Because,
will you do a routine CT for every patient?
in our institute, there is a long waiting period for CT, ma'am. So we do it if it is clinically relevant. If it is
So what is the clinical relevance? What is the clinical relevance?
ma'am, it can be again patient and tumor factors, ma'am. If it is a male sex and age-wise, if it is in extreme ages like less than 15 or more than 55 years, or in a family history of thyroid cancer or a history of childhood irradiation of neck, or in tumor factors like hard nodule with the
No, and the presence of a lateral node.
Yeah,
Now,
yes,
in the presence of lateral node, by default, you will do the central compartment.
ma'am, yes, ma'am.
But assessing the nodes is very important.
Yes, ma'am.
Okay. And then tumor factors, what are the tumor factors?
Ma'am, a large means a T3, T4 nodule, like a large thyroid nodule. And
Yeah, more than 4 centimeters.
yes, ma'am. With the fixity to surrounding structures, if it is not mobile, if the lower border is not felt, and if there is any pressure symptoms, if we want to roll out any mediastinal nodes also, in such
Yeah.
case, we can go.
So basically, Walker-Call palsy, lateral neck, complaints of dysphagia, fixity to the deeper structure, sudden increase in size, and even appearance of pain. All this becomes very evident that you need to do a CT scan for a local invasion also.
Yes,
So to rule out local invasion, CT scan is a must.
yes.
All right. So anybody wants to ask a question or I continue?
Yeah,
Please
madam, you
continue,
can
madam.
continue.
Okay. So you said you will do, so now what is the size of this nodule?
Ma'am, ultrasound wise, it is 2.4 centimeter, ma'am, on the right lobe and 7 into 4 mm in the left lobe, ma'am. Both are Tirade spine nodules.
Okay. And both are positive for Bethesda, both are positive for papillary?
No, ma'am, only right side nodule was tested for FNA.
Yeah, because the other one is 7 mm, so less than sub-centimeter nodules we normally don't do.
Yes, ma'am.
But then, will you, for a 2.4 centimeter nodule, will you do hemi with a nodule sitting in the opposite lobe?
Since the disease is bilateral and that too Tirade spine nodule on the contralateral lobe, it is better to go for total thyroidectomy, ma'am. If it was only unifocal disease, we could have done.
Yeah. So in that case, if your pathologists are smart, and if they can do USG guided nodule biopsy of the opposite lobe, 7 mm lobe, and if it is negative, and if the patient is young, you can still leave behind the opposite lobe and observe.
Okay.
You can. I mean, just for 7 mm nodule, which is histopathologically not proved, will you consider it as a bilateral disease and do a total? I'm asking you a question.
Yes, ma'am. If it is if FNA is negative, we can go ahead with hemithyroidectomy.
So normal circumstances, you wouldn't do a biopsy of a 7 mm nodule. But since you are in a very peculiar situation, that patient is female, patient is female.
Yes.
Is patient female?
Ma'am. 43-year-old female, ma'am.
Yeah. And finished childbearing also?
Yes, ma'am. She has 2 children.
Okay. So it's a little peculiar situation, but again, it's a young female. Childbearing is over, but risk of parathyroid and risk of recurrent laryngeal nerve damage cannot be underestimated.
Yes.
And that is the reason why I would, in a unusual situation, I will do FNSU of the 7 mm nodule. And if it is benign, I may decide to leave behind if the patient is good for follow-up patient.
Okay.
Because anyway, you are not going to do anything with this patient in terms of like it's a well-differentiated, low-risk patient.
Yes, ma'am.
Doing a total is not unjustified, but at the same time, in an era of conservation, you are not wrong if you do a biopsy of the lesion. If it is benign and then you decide to do only hemi, you are not wrong.
Yes, ma'am.
So you can give the option to the patient and then take a call.
Yes, ma'am.
What the others on the panel think? What are the...
I agree, madam. I agree completely.
Yes. So can you identify? I forgot who are with me. I just joined.
I'm Ratan, madam.
Ratan. So because Rini, it is not just the total and the hemi versus total ka debate we are continuing. It is the risk of parathyroid which should be utmost in your mind. Because we are not talking of your situation or your institute, but across the country, the expertise of the thyroid surgeon to preserve the parathyroid is also to be questioned and brought into the calculations.
Yes.
So you are not wrong if you answer like that, but you are not wrong if you say total also. You are not wrong. But I would definitely, myself will definitely do the FNSU of the 7 mm nodule and see what it is and then take a call.
Yes.
So what is your plan? You have already planned for total.
Yes, ma'am.
And what about the neck? What will you do with the central neck?
Ma'am, ultrasound wise, there was no significant notes, ma'am.
See, you can say about ultrasonography when the thyroid gland is sitting in the neck. Ultrasonography doesn't have that much of a accuracy to assess the central compartment nodes.
Yes, ma'am.
And that is the reason why we combine with the CT scan. But on table, what can you do?
We can send for frozen, ma'am, if you are feeling any suspicious looking notes.
Yeah, so the ATA guidelines also say that suppose if you don't have a CT scan with you, don't completely depend on a sonography. On table, you can do a good inspection of the central compartment, see if there are any doubtful nodes, sample them, do a frozen, and then take a call.
Yes.
Papillary, we have an advantage that they are generally blackish in color or grayish in color. So probably picking up the doubtful nodule is a little bit easier. I wouldn't say always, but little bit easier. And the central compartment inspection should come as an answer to the question, what will you do with the central compartment?
Yes.
You have to say that if I have a CT scan and which rules out the central compartment, then I'll be less worried. But if there are suspicious nodes on an inspection on the table, I will definitely sample them, do a frozen, and then take a call.
Yes, ma'am.
All right. Ratan, you can ask a question.
Yeah, Ginny, do we know any studies which have looked into this prophylactic central compartment dissection versus observation
Yes, ma'am.
for thyroid cancer?
In a study by Sergio et al., in 136 patients, he has done prophylactic central compartment neck dissection, sir. And in 82% of patients had lymph node mets.
Now I'm talking about with regard to disease-free survival or recurrence-free survival.
No, it doesn't affect at all. Long-term survival is not affected by whether you do the central compartment or not.
Yes. So there
And
are
the depth.
studies regarding that. The first
And that
study
is
was by
that is the reason why ATA changed.
yes.
From 2009 to 15, routine central compartment was done, and the rate of postoperative hypoparathyroidism went shoot up to the skies. And they changed this in 2015 guidelines with what we discussed just now. Now, I think that what Ratan says is very important, that you must know the studies and what changed the practice in from 2009 to 15. And I don't think the routine central compartment clearance has any advantage on the disease-free survival or a long or a this thing. So, can you want to say something, Ratan, on this?
Yes, ma'am. There are randomized control trials on this which have not shown any difference in outcomes with regard to recurrence-free survival. There was no difference in DFS. There are six, I think four or six. Last time I read it was four, and the first study was by Viola et al. There was no difference when they did prophylactic central compartment dissection versus observation for thyroid cancer. And
So
some one of these randomized control trial had T4 disease also, not just T1 T2 disease.
No, she's telling 82% were found to be positive on the final histopathology, which is you go and refer back. I think it is too high. I
So,
don't think
Ginny,
don't-
micrometastasis. See, the reason why they don't recommend prophylactic dissection is because even when you dissect, there will be lymph nodes. Micrometastatic disease is quite high. 80%. What you're saying is right, but it does not affect survival.
Yes,
Not
correct.
even recurrence-free survival. Not even DFS, I mean OS. And secondly, the difference in DFS was only 2%, 4% versus 6% in those who underwent central compartment and 4% those who did not underwent central compartment
Yes.
clearance. So the risk of recurrence is very low even when you do not do.
Yes.
So the problem with
And
the thyroid
I
surgery.
again want to highlight the importance of not damaging the parathyroids and
Yes,
recurrence.
that is
When you do
the
a
most
central
important thing.
compartment, when you do a central compartment, even in expert's hand, there is a risk of hypoparathyroidism. So there is no question of you answering as a routine central compartment. Please don't do this.
Yes.
All right. So go ahead. I was asking her what are the indications for recurrent laryngeal nerve sacrifice, madam?
Acha, okay. So answer, my dear Rini.
Ma'am, when the nerve is passing through the tumor.
No, you have to say preoperatively functioning now, and then on table you find something abnormal, and preoperatively gone now and on the table. So you have to answer it in two parts. So if
When-
the patient has a preoperative involvement, in the sense that if the patient has a recurrent laryngeal nerve palsy in preoperatively, what will you do? And if it is functioning now, but on table you find abnormality, what will you do?
Ma'am, if the patient is already having preoperatively vocal cord palsy, we can sacrifice the nerve, ma'am. And
But
if
sacrifice the nerve when?
on the side of vocal cord palsy, ma'am.
No, but not a routine sacrifice. Even if the nerve is paralyzed preoperatively and on the table you don't find a gross disease, you will not sacrifice. This nerve may recover.
Yes, ma'am. Only if the nerve is passing through the tumor.
Yes. Yes. And if there is a significant disease on the nerve, which will not allow you to do R0 resection, then a paralyzed nerve you will cut.
Yes.
Now you tell me, preoperatively nerve was functioning and now on table you find something.
We can shave it off from the nerve, sir. No, ma'am.
No, but then you have to say different situations, my dear.
Ma'am, if it is only adherent to nerve, we can shave it off from the nerve. If the tumor is only adherent to the nerve, we can shave it.
No. Yeah, if that is the only tumor which is likely to be left behind, everything else is clear, then you will shave it off.
Yes, ma'am. If there is gross disease, then if the patient is not benefiting from R0 resection, then we can save the nerve.
Yes. So that is what I was trying to tell you. If
Uh,
all the
Dini,
disease from all the disease from everywhere is removed, and if the tumor is involving the sheath, probably we will shave it off and depend on the radioactive iodine therapy. And at least function of the nerve can be preserved. We don't know whether eventually this nerve which is shaved off will work post-operatively, but at least it is likely to recover. So you will leave behind the nerve. But if the gross disease, it's a very bad disease and you are likely to leave behind a significant disease, then you will definitely sacrifice the nerve. But you will save the opposite nerve first and then come and sacrifice on this side. I think you should read my guidelines, my dear.
yeah, I was about to suggest the same, madam. ISTS
Beautiful,
guidelines,
beautifully explained in the guidelines with evidence.
It's fine.
So
algorithmic approach to
you have to
management of recurrent nerve.
read our guidelines very carefully if you are exam going student.
Ma'am, I have started it, ma'am.
Yes, yes. Okay, so
And-
that's about now, Ratan. Now, what else we can ask now? A central compartment ho gaya. Okay, if there's a lateral compartment, so okay, by default, when will you prophylactically do the central compartment? When?
Ma'am, ATA recommends only in T3, T4 disease or if the lateral lymph nodes are positive.
Right. So if the lateral lymph nodes are positive, you will prophylactically, electively treat the neck, central compartment. And if there's a T3, T4 disease, you will electively treat.
Yes.
Right.
Extrathecal extension. All right. T3, T4 disease. Yes. And
And
extent of your neck dissection, if it is therapeutic in thyroid cancer.
Sir, we'll clear 2 to 5 levels, sir. In lateral compartment and level 6, if it is positive in level 6, we'll do central compartment clear. When we'll do central compartment, we'll clear level 6.
yeah, correct. 2 to 5 and lateral 6 will be covered under central compartment. One will leave behind. One will leave behind.
Okay. Now,
How will you what are the clinical localization for parathyroids? There's some line, superomedial, inferolateral. Do you know about that?
Ma'am, in the coronal plane of recurrent laryngeal nerve, usually superior parathyroids are located dorsal to the nerve and inferior parathyroids are located ventral to the nerve. And superior parathyroids are usually located in the midway along the posterior border of the thyroid gland. And inferior parathyroids are usually located near or below the inferior pole of the gland, near the inferior thyroid artery.
But the location of the inferior parathyroid is very, 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 very inconsistent. It can be in mediastinum also, it can be, but superior parathyroids are relatively consistent. So how will you locate the superior parathyroid in the steps of operation? What do you do first and then you go to the superior parathyroid? What do you do?
Ma'am, visual identification.
No, but what step you do and then you will generally see the parathyroids?
After ligating to the superior pedicle.
Yeah. So basically don't say superior pedicle. You can say after ligating individually superior
Thyroid
thyroid vessels individually on the gland.
Yes.
When you retract the superior pole, generally you will find the superior parathyroid. Generally. What about the superior laryngeal nerve? What will you do for superior laryngeal nerve?
We have to preserve it while ligating the superior thyroid vessels, ma'am. It will be lying close to the superior thyroid vessels.
So what is the Sternia's classification?
Cernia, it is divided into type 1, 2A and 2B, ma'am. Type 1 is now crossing the superior thyroid vessel 1 centimeter above the superior pole of the gland. And in 2A, now crossing the vessel within 1 centimeter of the.
So basically, you can say one is usually 1.5 centimeter above the superior pole, and generally the nerve is safe,
Yes,
right? When it is 2A and 2B,
It is at
what happens? It could be crossing the vessels
yes, ma'am.
or it could be on the gland, right?
Yes, ma'am.
So if you do a mass ligature, you will definitely damage.
Yes.
But the nerve may not be seen. So will you routinely go and identify the nerve?
While ligating the superior vessels, we do identify the nerve also.
So what is the triangle called?
Joel's triangle.
How it is bounded?
Medially, it is midline, superior laterally, superior thyroid vessel, and superiorly, superior attachment of the strap muscles. And the floor is formed by cricothyroid muscle. Now runs along.
So basically, you will go and see this triangle first,
Yes,
and if you and all other levels, Sternia's level we saw that you will while you try ligating the vessel, you will definitely check. But otherwise, you will actively will not go and dig for the nerve, right?
yes,
Generally, you will find the nerve, but you will not just go and hunt the nerve. Sometimes it could be going below the the cricothyroid muscle, and you may not even see it also.
yes.
Thyroid muscle, I think. CT muscle, yeah. So basically, Joel's triangle you will definitely explore, look for the nerve. Generally, you may find, and while ligating the vessels, you must look for, and then if you don't find it, leave it. Ratan, would you like to say anything?
Nothing, madam. I think we are about to reach our time, madam. 7
Oh,
o'clock.
okay. All right. So, how will you manage the post-operative calcium check? How will you manage quickly?
Ma'am, ATA recommends routine administration of calcium postoperatively, ma'am, without checking the lab values. And
What about the vitamin D? Indian patients are very deficient in vitamin D. Will you check for vitamin D pre-operatively, and if they are found to be deficient, will you correct? Or
ma'am, if it is found deficient, we have to correct, ma'am, pre-operatively.
yeah,
But
but do routinely vitamin D also. I'll recommend that you should do it.
yes, ma'am, we are doing one study also, ma'am. Pre-operative vitamin D and post-operative incidence of hypothermia.
Yeah. So if your vitamin D is sufficient and post-operatively you are routinely giving calcium, then probably yes. But what are the symptoms on which you will be worrying and will do something? What are those symptoms? Perioral tingling and numbness. Perioral.
Yes, ma'am, tingling at the fingertips. And Chostek sign, we usually look for Chostek sign. And
That's too severe, no? You might have a mild symptoms and then you have a severe symptom. So how will you take action? What action will you take if it is perioral tingling or a little bit tingling in the hands and feet? What will you do?
for oral supplementation, we start with oral supplementation, ma'am. If patient is having significant numbness or muscle weakness or irritability, then we'll go for IV supplementation. And if the lab value is also significantly coming down, then we'll go for
No. But there's a fast acting agent. What is the name of that agent which you have to start?
calcium gluconate, ma'am.
No, that is IV, but orally.
Calcium,
Recalcitrol, huh?
ma'am, calcium citrate.
No.
Calcium.
Ratan? Recalcitrate, no? Short acting and fast acting.
Okay.
Just read up.
Yes, ma'am.
Read up. Because you have to start oral also. So vitamin D ka hai, calcium 3 times a day.
Yes,
Maybe like 500 milligram 3 times a day, and 1000 milligram calcium. That can be citrate, as you rightly said. And if the patient improves, fine. Otherwise, then IV line. IV line you don't start immediately. Yeah. But read up. You are not correct. You are not correct on that. I'll also send you if you send me high.
Yes, ma'am.
But you have to read calcium management of calcium.
Yes,
And-
Madam,
and
that is citrate only, madam. She was right in saying that, madam.
I'm not saying about citrate, I'm talking about vitamin D.
Okay, yes, madam.
sir,
We routinely,
Prophylactic
in
is
vitamin deficiency, we usually routinely give calcitriol also in
Hello.
sachet form and also the oral tablets form.
yes, ma'am.
Hmm.
With the calcium citrate, we give.
So she was mainly talking about IV calcium. So I said, please try oral first in TDS dose. And if that doesn't work, then calcium, because IV calcium has its own side effects to heart and everything. Rini.
Yes.
So you have to be little careful under the supervision, but oral TDS dose will be safe, and then you can think of IV. If the symptoms are too much or symptoms don't improve, that's what I was trying to tell you. And
Yes.
recalcitrol is a recalcitrol. It's a fast acting, I think. I also, the market preparation, I'm little forgetting, but that also needs to be given along point, and the dose of that is 25 milligram. That also I know. But the market preparation, I'll send you the message. I'll send you the message.
Yes, ma'am.
It what exactly? But you read up properly. The calcium management is given in most of the books, and read up properly. But don't jump to IV. That is what is I'm telling. If the symptoms are mild, you manage it with oral. TDS dose. TDS dose.
Yeah, the
But if
brand
the
name is Roll Calcerol, madam. Roll
Huh?
Calcerol, 0.2 microgram, 2 QID. You can give, or a sachet as QID dose we can give.
Right. So that. So anything else? How many minutes left? You have any query, Rini? You have any query?
Ma'am.
No.
Ma'am, I'll read your.
No. Do you have any query to ask us? I'm asking. See, when it will go off, it will go off. If the Zoom is going to go off, but till the time you can continue. If you don't have any questions to us, then we will ask you the questions. So, what will be the extent of your neck dissection? Central neck, boundaries of the central neck, boundaries.
Ma'am, from cricoid to brachiocephalic trunk and between two common carotid arteries.
Cricoid?
Actually, three people have given differently, ma'am. In central compartment, we usually start. It is bounded superiorly by hyoid bone and inferiorly.
Yes. So say that only. Superiorly by hyoid bone, inferiorly by innominate artery, carotid to carotid if it is bilateral, and single same side, trachea to carotid.
Yes, ma'am.
But when you actually dissect,
Yes, ma'am.
if the lesion, now you tell me, if this lesion is superiorly placed, more lateral, and superiorly placed and inferiorly placed, there is a difference in that.
Yes, ma'am.
So why do you say from cricoid? What is the logic to say from cricoid to innominate?
One study I had read, ma'am, from.
Don't talk about one study, yaar.
Okay, ma'am.
Don't talk about one study.
Ginny boundary, upper boundary is hyoid only.
Ma'am,
Of
yes, ma'am.
course, upper boundary is hyoid and inferior boundary is innominate.
Yes, ma'am.
And lateral is carotid to carotid for bilateral and trachea to carotid for unilateral. If you are doing a unilateral neck dissection, it will be that much. Now you tell me the logic which you gave is not correct.
Yes.
And what is along with the lymph node, what do you dissect out? What is main dissection? It's basically a fibrofatty tissue, all the fibrofatty tissue.
Yes,
So
ma'am.
you literally skeletonize the whole recurrent and parathyroid, and except this two, everything else, all fibrofatty tissue containing the nodes are cleared from innominate to this thing.
Yes.
But yes, you are right that in select situation you may not go up to hyoid. That I agree, but that you read up properly. Not one study, huh?
Yes, ma'am.
Okay. And if you have any question, you can ask. Complications generally are related to hypoparathyroids. You have to do 70 degrees scopy for the patients preoperatively and postoperatively for recurrent and nerve functions. And where will you place your incision for thyroidectomy?
Low skin crease, ma'am.
Low skin crease. That's a good answer. If the patient is very young, no crease.
We'll have to go for other techniques.
What?
We'll have to go for other techniques, ma'am, without
What? But that you have to say.
like robotic or
No. I'm saying that if the patient is very young and there are no neck creases, where will you take your incision?
2 centimeter above the suprasternal nose, ma'am.
Yeah, but it is a little, then it is better to go on a cricoid, little bit on a cricoid. If it is a young patient, it's better to go on a, just at the cricoid or a little bit at the cricoid. And otherwise, 2 centimeter above the suprasternal notch is not a bad idea. It's also good. Now, you may be asked about robotic and you may be asked about whatever. So what will you answer on that? Will you prefer open or will you prefer a robotic? And logic or pros and cons of each.
Open, I prefer open, ma'am. It is less
Yes.
time consuming.
So what is the cons for robotic surgery?
It is time consuming process, ma'am, and the cost is also too much. And there'll be extra incisions in the axilla also. And
Basically, cost of the robot is a steep learning curve. It's a huge learning curve. It's not easy to operate on the opposite tracheoesophageal groove from this side when the trachea with the patient's extended position becomes like a rock or like a mountain. And then you have to go on the opposite neck, do the thyroid, preserve the recurrent angionovis in the groove, preserve the parathyroids, and probably inspect the neck. So we are not against robotic, but these are the very difficult situations. I mean, genuine difficulty with the robotic. And though it is a scarless in neck, but there are scars somewhere else.
axilla.
So just to say to not to have a scar in the neck, you will do robotic is not a very good justification compared to the cost, long steep learning curve, and even a possibility of living behind the gross disease
Yes, ma'am.
and damaging the structures like recurrent and parathyroid. Because you cannot visualize the way you visualize with the naked with the open technique. Plus, in open technique, you can use your adjuncts like loop, yes, loop, parathyroid localization, nerve monitoring, everything. So with these adjuncts, open technique is any day safer to the patient, cheaper to the patient, and easily replicable by any surgeon who gets trained for open. It's not the same with a robotic surgery.
Yes.
I think I'm exhausted of questions now. I don't know what to ask you.
Ma'am, actually,
If
ma'am, we have actually, I mean, we can have another 5 minutes. Otherwise, ma'am, we can wrap it up also because it's close to 7:20.
No,
And-
I don't mind wrapping up. Please.
No,
No,
ma'am, we
thank
can have for five. I mean, we can have discussion for another 5 minutes. I was just telling you. Yes, ma'am. So
Yeah,
if you have more questions, ma'am, you please proceed.
So, it's no brainer that if the opposite nodule was positive on the FNC, we would have done total. But since you are in a very peculiar situation, low risk patient, 7 mm nodule, if it comes negative, I'm not going to chop off the opposite node.
Yes.
What about the observational, like one is operate, the other one is observe. So what is your take on that? Who is the main surgeon who started this? From where? What is their data and what is their opinion on this? Rini?
It is a Japanese study, ma'am.
Yeah. So you should read up. It's and Ito, like the person who is now writing more
is-
about it is Ito. Yeah.
Ma'am,
So basically, what is the logic behind that?
they have done 50 study on 1,235 patients, sir, patients, ma'am. And only 191 patients required surgery. And the mean follow-up period was 6 years, ma'am. So,
The main reason to operate was, I think, the anxiety of the patient also was there, and some of them increase in size.
yes, ma'am.
Patient concern was also a part of the reason why they reoperated. And second thing is, the second thing which you should read up is the radio frequency and microwave ablation, pros and cons of everything in cancer, which is microadenomas. Radio frequency is definitely superior than microwave. And you should read up about everything in cancer, not in benign. I'm talking of cancer. You must know about that modality as a treatment for contraindication, indication for radio frequency, posteriorly based, very near to the retinal nerve. All those patients becomes contraindication, but otherwise microadenomas can be treated. There is a data now for radio frequency from Stanford group, and also the microwave ablation. Microwave ablation is more invasive than the radio frequency, and then you should read up for everything about that. Yeah.
Yes, ma'am.
Okay. So we wind up now. Thank you. Thank you so
Thank
much.
you, madam. Thank you, madam.
Thank
Have a good evening, madam.
Yes. Yes.
Thank you.
Thank you, ma'am. Thank you, Dr. Ratan. Thank you, Elizabeth, ma'am, for being a part of this and sparing your time on a Thursday evening. Thank you, Ginny. You did well. I just one last thing. Can the examiners please give her some marks out of 10 so as she knows how has she performed in this case presentation?
She has answered most of the questions that we asked. We actually started at 6 o'clock, madam. So the studies by Ito and Sugitani, all that she had answered. Maybe she is tired of answering so many questions. She has done really well. So I would give her 9 out of 10. And I would like to congratulate her teacher, Elizabeth, madam, also for training us so well. But
Thank
you have to be thorough in your answers, and you cannot mess up with all the figures and all. Okay.
I'll-
And please read ISTS guidelines, which was authored by uh, Madam,
Yes,
JPD Madam.
I have
Okay.
started. Thank you, sir.
Yeah, and wish you all the best. Thank you. And thank you, Madam.
Thank you all. Thank you.
Thank you, everyone. Thank you, Jyoti, ma'am. And we'll conclude this now. Have a good evening, everyone. We'll be back after 15 days with another topic and another set of examiners. Thank you.